Hey guys, am I audible? Am I visible? If so, say me a hi and a hello. Okay, great. I hope I'm audible and visible. A very good evening, everyone. So today we will go to the first chapter of pathology. So what we have done in FARRE is we completed hematology first, then systemic pathology, then we came to general pathology. So today, as you can see, I'll be talking about cell injury, inflammation, and whatever we left in the genetics from the previous module, right? So this time I'm going to go fast because these are topics which I'm sure most of you will be keep on using it frequently. Must have read it frequently and must have revised it frequently because it's the first chapter, right? Because generally first chapter is where we have all the enthusiasm, and the enthusiasm kind of fades away over the period of time, right? And like I said, like you guys requested multiple places, I will definitely take a FARRE on bone, CNS, and other things, but maybe not in this channel. Like I said, I'll be taking in my channel, right? Because from tomorrow, I think tomorrow, day after tomorrow, you will have a practicals FARRE of micro, path, and pharmacology, which will also be there in the Meta channel, right? So let's go quickly. Let's keep see and let's revise about the topics of cell injury, inflammation, and genetics, fine? The first thing is about cellular adaptation. If you ask me like will they ask a question on cellular adaptation, I really don't know, fine. Okay. Good evening everyone. Because this is a very simple topic in a first internal, this might look like an amazing topic, but at the fag end of pathology, I think you will be able to write more than what is given in Robbins or any book, right? Because we have the entire understanding of the cellular adaptation with hyperplasia, metaplasia, hypertrophy, or atrophy, right? Okay. Tejas, I have shared it to them today. They'll upload it in the Mediators soon. Fine. I'll also put in the WhatsApp group as well. Fine. Okay. So before going to cellular adaptation, I want to ask a few questions. Let's see if you guys can answer. Right. As usual, doesn't matter if we are wrong. Allah, I'm doing good. Hope doing good as well. Tell me whether cellular adaptations are reversible or irreversible. They are amazing, Arya. They are definitely a reversible process. Can cellular adaptation result in, lead to cancer or neoplasia formation? Yes, no, maybe. What do you guys think? Yes, definitely it can, right? So, of the cellular adaptation, which is one cellular adaptation which can never progress to a cancer. Perfect. Cellular adaptations are reversible. Yes, they can result in cancer. One of the cellular adaptation which will not go to a cancer is hypertrophy for a matter, right? Perfect. So now let's go deep dive in and look at the superficial parts of the hyperplasia, hypertrophy, metaplasia, and atrophy. If at all, if it comes in a short answer, you should be able to pen down something. That's it, right? Hyperplasia, as the name says, it's increase in the cell number. That's hyperplasia. Hypertrophy is increase in the cell size, right? We do have in everything physiological as well as pathological. The best examples of physiological hyperplasia are normal hormonal changes. For example, menstrual cycle. During the proliferative phase of menstrual cycle, we have estrogen and the endometrial proliferation happens. And you guys know for a fact that great Allah, once you have the ovulation, estrogen stops and the proliferation also stops, right? If the same physiological process persists, it will result in having an endometrial hyperplasia, right? So what are the reasons or causes of endometrial hyperplasia, which is pathological, right? So I should have a persistent estrogen, which means when there's no ovulation, obviously estrogen will not drop, estrogen will keep on increasing. PCOD, PCOS, they have changed the name, the metabolic syndrome and everything with related ovary, that also will increase in the terms of the estrogen exposure. Obesity, it will be the peripheral conversion of fat. I have put obesity in red mark because obesity is only condition where I would put them under non-treatable cause, because obesity, you know that you'll have a gym subscription, but we never try to reduce the fat, right? It will never reduce it, right? So because of that, obesity is a very silent pandemic, and obesity is where the estrogen keeps on persisting more and more and more. If estrogen persists more and more in any woman, can anyone tell me what will be the complication? Next, we have a tumor, because granulosa cell produces estrogen, that also will cause hyperestrogenism. Whenever we have hyperestrogenism, automatically it results in a microscopic condition called an endometrial hyperplasia. That's a disease. How will be the symptoms of the disease? The patient will present with menorrhagia or excessive bleeding, and the treatment is going to be based on etiology, right? So this is a pathological hyperplasia named as an endometrial hyperplasia. So how do I diagnose an endometrial hyperplasia? Patient comes to the symptom. Now you must have gone to the OBG postings. You must have definitely seen patients coming with abnormal uterine bleeding. You do a uterine curettage. You take the sample, give it to the pathologist. So what I see in microscopy is this. A normal native endometrium will have 1 unit of gland and 1 unit of stroma. And an endometrial hyperplasia will have more units of glands and less unit of stroma. When the gland to stroma ratio gets altered from 1:1 to 2:1 or 3:1, I'm going to term them endometrial hyperplasia. Can this become cancer, guys? Yes, obviously it can become cancer. Like I said, when it's an obesity, when there's persistence, I'm not able to treat the cause. I'm not able to remove the factor. Definitely, it can go and it can progress to an endometrial adenocarcinoma by default, right? So that's about a simple talk about hyperplasia. You can write it for anything. Physiological, when you fall down, bone marrow compensates, compensatory hyperplasia. Hemolytic anemia, bone marrow will undergo hyperplasia. That's also in compensatory hyperplasia, right? Simple. Liver, you cut, it grows and completes it. It's also compensatory hyperplasia. Like I said, the first chapter is very, very easy because you have completed the entire pathology. You can write examples more than what you already know from the textbook. So please don't limit yourselves only to the textbook. Explore, add more and more things. If it's relevant, definitely please use them. Fine. Okay. Now let's go to hypertrophy. Hypertrophy. Can anyone tell me which cells will undergo hypertrophy? If I say, okay, this cell will undergo only hypertrophy, is there anything like that? Is there anything like that? Yes, cells which has lost the capacity to divide. A cell which divides can undergo hyperplasia. A cell which has lost the capacity to divide can undergo only hypertrophy. The best example for them is striated muscles. Right, your cardiac muscle, your skeletal muscle, which are striated muscles, they don't have the capacity to divide. The only possibility or adaptation they can have is hypertrophy. At the same time, smooth muscle, which has the capacity to divide, can undergo both hyperplasia as well as hypertrophy for that example, right? So increase in cell size. When there is no cell division involved, obviously it is going to undergo only one outcome is hypertrophy, right? So what happens in hypertrophy? The best example is your exercise. The more muscle you build, it's nothing but the protein, right? The protein means it's a cytoplasm. The nucleus converts more of them to mRNA. mRNA converts more of them to cytoplasmic protein. The cytoplasmic protein increases the size of the cell. That's a simple mechanism of hypertrophy. That's all. Fine. Okay. Anonymous, thanks a lot. If you have any suggestions, do let me know. I'll try to improve. Fine. This is a FARRE. This is not a main class. It's just to follow. Okay. So physiological example, skeletal muscle undergoes hypertrophy because of pure increase in the size due to increase in muscle mass, that's all. Pathological, like I said, the same striated muscle we have in cardiac. There are two forces which will be increased which causes hypertrophy. That's your preload and other one is afterload. Preload, your end diastolic volume is a preload. When there's more preload, automatically my end diastolic volume in the ventricles becomes a little bit more, and there's a more afterload, the total peripheral resistance becomes more, right? So whenever there's an increased preload with respect to left ventricle, you can give an example for any ventricle for that matter, right? Or an atrium for that matter. Whenever there's more increased preload in left ventricle, which means the aorta is not closing properly, so the end diastolic volume increases in case of aortic regurgitation. There's a volume overload in aortic regurgitation, right? So when volume is there, any fluid for that matter, it will automatically go to the least dependent part, or here we have the apex. So what happens? The apical part alone will undergo more hypertrophy, right? That is an eccentric cardiac hypertrophy. When you take systemic hypertension, right, it's volume and pressure. Total peripheral resistance is nothing but, which is the one which contributes to blood pressure. So when I have more blood pressure, total peripheral resistance is more, so my heart has to pump against the forceful push, right? So when you have a pressure overload, you will end up in having a concentric hypertrophy, which means the entire wall of the heart is going to become thicker because pressure is always uniform, not like a volume, it will go to the corner, right? So we have concentric cardiac hypertrophy. These are two hypertrophies which are seen in pathological conditions. You see them day to day because hypertension is pretty common, right? Systemic hypertension is pretty common, and most of them long-standing case will definitely end up in having your pressure hypertrophy or concentric cardiac hypertrophy of the heart. Fine, perfect. Now let's come back to this. So how do I identify hypertrophy in a microscopy? It's simple, right? Good evening, Sudhi. Very easiest way to identify hypertrophy in a muscle is you look at the muscle fiber. Muscle is a mesenchymal tissue. You'll have an elongated cell, which means the nucleus will be blue and it will be elongated. The cytoplasm is the one which becomes more in hypertrophy, right? So that's all. If you have more pink color cytoplasm, that means I have more muscle contractile protein, which means it is normal. If you have, this might not be a very representative image, but I have showed you the images in the Robbins as well as in the Niche batch. When I have more muscle, definitely I'm going to say it's hypertrophied muscle, that's all. Can hypertrophy result in cancer? No issues, Anonymous, not at all. It's your choice, it's a free world. Can hypertrophy become cancer? Can it progress to cancer? Yes, no, maybe. It's simple, right? It will not progress to a cancer because hypertrophy does not involve cell division. When the cell is not dividing, it definitely does that. Fine. Yes, Siddhi, I'll do it for sure. Okay. When the hypertrophy is not going to involve cell division, whenever there's no cell division, obviously there's no increase in risk of cancer. Hypertrophy is one cell adaptation when formation of cancer is almost impossible, right? That's your hypertrophy. We have physiological, we have pathological. There are a few more examples which are irrelevant. For example, uterus will undergo both hyperplasia and hypertrophy because of smooth muscle. It can add to the text box, it can add to your answer sheet, but in real life, no gynecologist is going to be worried about that, right? Because everyone knows that uterus will increase in size with respect to pregnancy, right? That's simple, right? So yes, I can increase the pages to write them. You can use uterus. You can use any place where I can have like breast parenchyma. I can have a hypertrophy and hyperplasia during pregnancy and puberty, lactation and puberty, right? You can add them, but not relevant for me for a clinical point of view, right? That's a second cellular adaptation. The third one, again, I'm going to start with a few questions from you. Can anyone tell me, define metaplasia? If I have to ask you to say in one word, tell me what is metaplasia. Can anyone define metaplasia? Just a single word, define metaplasia. Metaplasia is nothing but, sorry for that. Metaplasia is nothing but, it's a change in one adult epithelium or a mesenchyme into another adult epithelium or a mesenchyme. That's all, right? It can be epithelium or it can be mesenchyme. Generally, we concentrate on the epithelial part only, right? Metaplasia, meta means change. Plasia is obviously growth. It is change from one adult mature epithelium to an other adult mature epithelium or even mesenchyme. Mesenchyme is not very important for us. Epithelium is definitely important for us. You will definitely know about Barrett's esophagus. The reason for metaplasia is simple. Whenever there's a stimulus, long-standing, it can alter the stem cells' function. The most important word which I'll be looking for in the mechanism is they reprogram the stem cells. Be it GERD, be it smoking, which are the common examples of metaplasia, can reprogram the stem cell, which normally produces one epithelium. I reprogram them and I make them to produce another epithelium. Whenever stem cells are involved, what is always the risk? I always will have an increase in risk of a cancer. Never ever forget that, right? Now, let's go with the common examples. One of the commonest examples is Barrett's. Barrett's, by default, you will know the reason for Barrett's esophagus is chronic GERD. Chronic, persistent, recurrent gastroesophageal reflux disease. The acid goes to the esophagus. Esophagus cannot sustain acid. So the squamous epithelium moves to an epithelium which can sustain the acid, which is columnar epithelium and production of mucin, right? So obviously you need mucin production. So squamous cannot produce, so it changes to columnar epithelium and we call it columnar metaplasia. I'm just going to hide this. Can anyone tell me what is the classical endoscopic finding of Barrett's esophagus? Can come in the Viva. It doesn't matter whether it's from the esophagus chapter or from this chapter. What is that? Hi, it's me. Good evening. It is classical red velvety mucosa. We also learned in the Nishchay batch why red velvety mucosa. Because columnar epithelium is a single lining epithelium, right? Okay. And by default, the mucus or the blood vessel below that is much more visible. So columnar epithelium anywhere in the body will be more red in color compared to squamous epithelium, which is multiple, which is stratified and it will obviously be pale, right? So that's a red velvety mucosa. And when you take a microscopy, good evening Taleb, good evening everyone, right? What happens is you will see goblet cells, you will see mucin, and also obviously you will see glands. So the other name of Barrett's esophagus, I can call it in columnar metaplasia, I can call it in glandular metaplasia, or I can call it in mucinous metaplasia. Hi Sagar. Fine. Mucin is clear. Sometimes I might be struggling to identify mucin. In that case, I can use PAS or an Alchian blue. Both of them are mucin positive. It will be positive for mucin stain. Fine. Okay. That is the one of the metaplasia which is commonly discussed among MBBS students. But it's not the commonest metaplasia. Can anyone tell me the commonest metaplasia? Hi Sagar, I saw you and I said good evening to you. Okay. One of the commonest metaplasia is smoking induced metaplasia, right? So when a smoker smokes for quite some time, the particles in the smoke will definitely alter the respiratory epithelium. The normal respiratory epithelium is pseudostratified ciliated columnar epithelium. When smoke hits that, automatically pseudocytic ciliated columnar epithelium will move into squamous epithelium, which is much more resistant to smoke, right? Smokers, here it will be replaced by squamous epithelium. But the problem here is whether I'm not able to stop GERD or not able to stop smoking, it is involving the stem cells. So definitely there will be an increased risk of cancer. And smoking related metaplasia is one of the most commonest metaplasia. Fine. Okay. So obviously in the respiratory tract, we'll have squamous cell carcinoma. And obviously in your Barrett's esophagus, we'll end up in having adenocarcinoma, right? I have not included this, but I want you guys to give me at least one example for mesenchymal metaplasia. If it's a short answer, I want you to include mesenchymal metaplasia as well. But if it's an entire short answer on cellular adaptation, which includes all four, don't go with the least important points. Fine. Mesenchymal metaplasia, one of the best examples is simple. What's the example? It's your myositis ossificans. If you've gone to the orthopedics posting, I'm sure some of you must have definitely been to orthopedics posting, and you must have definitely seen that, right? Mesenchymal metaplasia is one of the metaplasia where after a fracture of bone, when you rub it or when the growth factors come outside, the bone forming growth factors will convert the soft tissue or the muscle into bone. That is myositis ossificans. It's not an inflammation, it's a muscle formation in a non-bony place. We call it myositis ossificans. One of the examples for mesenchymal metaplasia. Fine, clear? That's about metaplasia. Things to remember: one adult mature to other adult mature, reprogramming of stem cells is by default the mechanism of action. Examples of squamous, smoking induced, columnar Barrett's esophagus, and your myositis ossificans if required. Fine, perfect. Now the last but not least, atrophy. One of the important things for me for atrophy is something which is a gross terminology. Microscopy, we generally don't use the term atrophy, but in some place in pathology, we also use microscopic atrophy, right? It's reduction in cell size as well as number of cells. It's not just the number, it's the size and the number. Because it's both number and size, we have multiple mechanisms of atrophy. Because it's both number and size, we have both irreversible and reversible. See, once I reduce the number of cells, which means I'm killing the cells, it cannot come back. When I reduce the size of the cells, yes, it can come back again, right? So the most common mechanism is your autophagy or ubiquitin proteasome pathway. Definitely there's one more mechanism of apoptosis also. Apoptosis is microscopic, atrophic is a gross terminology, remember them, right? Okay, I do have the most common autophagy or ubiquitin proteasome related degradation, and by default I have irreversible thing, which is apoptosis, right? So what all causes atrophy? It's simple. Whatever is required for my cell to survive, if I don't have that, I'll be atrophied, right? You need food to survive. The same way your cell also needs food to survive. It needs blood supply, oxygen, proteins are required, nerves are required for some, right? I have to use the organ. If I don't use that, obviously it'll get atrophied, right? The best example for that is post-fracture. You have fracture, you don't use an organ, obviously the muscle becomes smaller. Hemiplegia, the nervous system is not working. I'm not able to move the limb. It will get atrophied by default, right? Hormonal atrophy. Put a star mark here. Menopausal. Post-menopausal, endometrium cannot divide. Can anyone tell me whether this is reversible or irreversible? What do you guys think? Reversible or irreversible? It is definitely irreversible. Even a hormone replacement therapy will not make menstruation miraculously come to a person who has undergone menopause, right? It's an irreversible change by default, right? Again, pressure. I need a space for a cell. If you have a huge tumor in the pituitary, compressing the optic chiasm, destroying the optic chiasmal cells, causing visual field defects. I have a huge tumor in the kidney, destroying the entire renal parenchyma and causing renal failure, right? Pressure also can cause atrophy, right? So what happens is, so whenever I have the requirements for a normal cell, if they are not met with, lysosomal eats excess mitochondria and excess cell organelles because I have to conserve the energy. And these excess materials are definitely stored in cells. See, it's a dead thing. It's a waste product. I'm not able to throw it outside because the cell is still living. For me to throw outside, I have to rip off the cell membrane. Cell will die. So cell is living. I'm destroying few of the organelles, mitochondria, Golgi apparatus and everything, but I'm not able to throw them outside. So I have to keep the dirt inside the cell. Those accumulated debris are lipofuscin, and they are seen in the perinuclear location, right? That's a classical finding what is seen in microscopy. Because of the reason we gave the term brown atrophy of the heart. That's a term given for like 70, 80 years old, automatically the brown pigments keeps on accumulating. Fine. Okay. Only one exception. Atrophy generally does not cause cancer. Atrophy is generally reversible. One which is irreversible is endometrium, and one where there's a risk of cancer is also endometrium. Endometrial atrophy can increase the risk of mutations, can increase the risk of cancer. Do remember that. Fine. Perfect. That's in short about the 4 types of cellular adaptation: hyperplasia, hypertrophy, metaplasia, and atrophy. Right? Clear? Any doubts? Do let me know. If not, let's go to the next one. Before going to the next one, I will ask you questions and I want you guys to answer. Clear? Perfect. Now let's go to the second topic. Again, one of the commonest thing which you must have revised, that is necrosis. Okay. I'll start with the easier one. What's the most common type of necrosis? I'll keep asking you questions. You comment on the answer. I'll answer it later soon. The most common type of necrosis, definitely coagulative necrosis. Necrosis has inflammation, yes or no? Next. In necrosis, in the reversible part of the necrosis, like the reversible part of cell injury, what's the most common ion? Second, what's the most common ion in the irreversible part of cell injury? Necrosis will have inflammation. The reversible part, the reversible injury, the most common ion is sodium. And the irreversible part of the injury or the cell death, the most common ion is calcium, right? That's what necrosis is. Necrosis is almost always pathological. Necrosis can never be physiological. On the other hand, apoptosis can be both pathological and physiological. Necrosis is only physiological, right? Everyone knows about necrosis. If a long answer comes on necrosis, thank goodness. Your university is a good university, because something most of the students will know by heart. So when they say, explain the mechanism of necrosis, I want you to start from reversible injury. It's not only the part of cell death. It is a process, right? So you have to start with, when cellular adaptation fails, obviously my job, the cell will go into a place where it's going to get injured. I have a reversible cell death and then I have an irreversible cell death, right? So necrosis or injury, the mechanism, the most common cause of necrosis by default, hypoxia. Hypoxia is by default one of the most common cause of necrosis, and the entire template of necrosis and cell injury is learned with the help of hypoxia. Whenever oxygen reduces or the blood supply, that's ischemia, it reduces, my cell will not be able to produce good amount of ATP. This is the first biochemical change. This is true for my skin, true for my heart, true for my brain. When ATP reduces, sodium potassium ATPase will not function properly, right? Because of altered sodium potassium ATPase, there will be increased sodium accumulation inside the cell. When sodium accumulates inside the cell, what will happen? The osmotic disturbance happens. Sodium is more there. I'm going to have more and more and more water coming inside. When water comes inside, what will happen to the size of the cell? It becomes swollen. That's the first light microscopic change in cell injury. This is not light microscopic, it's biochemical. I cannot see an ATP. It's a biochemical change, right? The first change is light microscopic change is cell swelling. Cell increase in size. I can call it cell swelling. In different places, I call it different name. I can call in some place cloudy degeneration, hydropic degeneration, vascular degeneration. Have you heard the term ballooning degeneration? If yes, can anyone tell me where have you heard the term ballooning change? Vascular degeneration is very common term used in kidney. Cloudy change, kidney. Hydropic, multiple places. Ballooning is especially used for hepatitis. Again, it's a liver change, which is reversible change of the liver. That's all, nothing else. It's accumulation of water, different parts of the body, we call it different. That's first microscopic change. I do have another microscopic change, light microscopic change, which is fatty change. Fatty change is not seen in every organ. See, fatty change is very common in liver, because the function of liver is to metabolize fat. The moment liver gets damaged, the metabolism of the fat will not happen properly. It starts accumulating fat and have fatty change. So these are light microscopic change. The same I can see ultrastructural or electron microscopic. 2-mark question. If someone calls something as an ultrastructural change, it is electron microscopy. My endoplasmic reticulum will swell. The water comes inside, goes there also. The moment endoplasmic reticulum swells, what will happen? There are rough endoplasmic reticulum, ribosomes are attached to it, that will be detached. Once that is gone, my protein production will reduce. My cells will form bleb formation because it's about to burst. So there are weak areas where there will be bleb formation. Whenever there's a bleb formation, what happens is in the site of the bleb, it's weaker because phospholipid bilayer is destroyed. That destroyed phospholipid bilayer can be seen in microscopy as myelin figures. I can see them in reversible as well as irreversible, because in irreversible it ruptures damaged phospholipid bilayer. At the same time, the same change in mitochondria, we call them amorphous density. Reversible, less amorphous density. Irreversible, more amorphous density. There are two findings: myelin figure and amorphous density of mitochondria is seen in both reversible as well as irreversible cell damage. Especially it will be useful in one mark question. Your MCQs are there in universities, right? All of the following are seen in reversible except, please remember, myelin figure and your amorphous densities. Look at the quantity: small amorphous density reversible, large focalin irreversible, right? Hi Jas, hello. Okay, so this is reversible density. The moment I have cell bleb formation, it's a weakening of membrane. A weak membrane will make it more permeable to one of the important guys, which is calcium. So when there's an increased permeability calcium, calcium comes inside. Calcium is a cofactor for many enzymes. So what will calcium do? It will go and activate one by one enzymes. It will activate phospholipase, it will activate protease, it will activate nuclease. When phospholipase is activated, the bleb will rupture, gone. The hallmark of necrosis is your membrane damage or membrane rupture, irreversible membrane damage. It cannot stick back again. Proteins will get destroyed. Normally, protein is pink in color. A destroyed protein becomes more pink in color, eosinophilic. If you have listened to my lecture, I must have told you the easiest example to remember. Egg protein, right? Normal egg protein is clear. You boil egg or you put an omelette, it will become opaque because destroyed protein precipitates and destroyed protein will be more pinker in microscopy. Same happens to nucleus. I had a normal nucleus. First, I destroy them, so I shrink them. Smaller nucleus, pycnosis. Then the nucleus still acts, cuts the nucleus into bits and pieces. Karyorexis. Karyo is nucleus, karyotyping, right? Rexis is breaking. Then that broken part also will be destroyed, which results in karyolysis, right? So in a H&E, at the end, what I'll see in necrosis, only pink color, because everything blue will be gone. The nuclear changes at this alone can come in a viva. I have pycnosis, karyorexis, and karyolysis. That's all. Fine. Now, I have a damaged cell. Can the intracellular contents come outside? Yes or no? Can you guys comment on that? 100% intracellular contents will come outside. When the intracellular contents come outside, the damaged part of them, when they come outside, right? So what we are going to see is you will have something called as DAMPs, damage associated molecular pattern. These are necrotic products, damaged products of the cell. They are coming outside. This DAMPs is the one which will attract WBCs. Okay, that will cause inflammation. So inflammation will be present. It will be painful by default because it's pathological. Everywhere it is inflammation, rubor, calor, tumor, dollar, loss of function will be there. And the most important thing, the intracellular contents coming outside will result in leakage of the enzymes outside. That's what we use for troponins, for myocardial infarction. AST/ALT for liver. This can be reasoning why question. They can ask you, tell me why there is increase in troponin in a myocardial infarction. Answer is simple. Myocardial infarction microscopically causes necrosis and irreversible cell death where the cell membrane will be damaged. So obviously the intracellular contents leak outside. That's why troponin is increased. Lots and lots of biochemical tests based on that with respect to necrosis. Do remember, why does AST/ALT elevate in liver failure? Same cause. Why does creatine kinase increase in muscle damage? Same cause. Whenever there's necrosis, intracellular contents come outside and I use them for biochemical testing. Fine. That's about necrosis pathogenesis. Types, I'm sure you know everything, right? But just quickly look at the types. We have coagulative, we have liquefactive, we have fibrinoid, we have fat, and we have gaseous necrosis. 5 different types of necrosis, right? So coagulative is definitely the most common form. I don't think you, yes, Arya, I don't think you will be wanting to read this again. Most common, every solid organ infarct will have coagulative necrosis except one infarct, which is brain infarct, which will have liquefactive necrosis. Dry gangrene is coagulative because just occlusion. Wet gangrene is liquefactive because in wet gangrene, I have suppuration, extra supraorder infarction. That's liquefactive, right? Main mechanism of coagulative necrosis, protein degradation. Destroys everything, including enzymes. The main mechanism of liquefactive necrosis, enzyme activation, or for example, lipase. Because acute pancreatitis is a commonplace. Then also in brain is abundantly rich in fat. I cannot destroy brain with proteases. I need lipases. So I have to activate lipase to destroy brain. That's why brain is liquefactive. Acute pancreatitis, you know what's a mechanism, right? What's a mechanism? All the pancreatic enzymes will come outside. Trypsinogen, chymotrypsin, lipases, amylases. So when they come outside, the entire pancreas will be dissolved. Right? That's a mechanism of acute pancreatitis. Again, enzyme activation. Wet gangrene, where will I get the enzyme from? The incoming WBCs. The WBCs will have the enzyme which causes liquefaction in wet gangrene or in any abscess cavity for that matter. Right? So since here, activation of enzymes is the main mechanism of destruction, it will destroy completely because they're very, very, very powerful. So microscopy, there'll be no background architecture at all. It will be completely gone. In other words, we call them ghost cells will not be seen. I will not see the outline. But a coagulative necrosis, I have a cell here. They don't destroy everything. They go inside and destroy everything. So what happens? The shell will be behind or the ghost cells will be there and the architecture will be the same. Fine. Okay. Perfect. That's the difference between coagulative and liquefactive necrosis. Perfect. Then we have few more types of necrosis. I don't think you'll ever forget it. Caseous is something which you've been reading again and again and again. Cheese-like caseous, right? Microscopy, it's a granular variant of coagulative necrosis. And one place I will see them is TB. Never forget TB. Other histoplasma coccidiomycosis, if we forget, I'm okay with that. Not very common, but TB, definitely. Pure neuritic leprosy, definitely. Okay? These are two important things which you never forget, right? Fibrinoid. Oid means like. Fibrinoid is fibrin-like necrosis. I will see fibrin or fibrin when there's a blood clot, which means when a vessel is involved, vessel is damaged, we get a fibrinoid necrosis, fibrin-like necrosis. That is vessel wall necrosis. Anything which damages vessel wall, you can write it. Vasculitis. SLA is a type of vasculitis. Malignant hypertension. I'm going to ask you a different question from kidney. Can anyone comment what is the gross finding in case of malignant hypertension? Gross finding for malignant hypertension. Your flea-bitten kidney, right? The same. In microscopy, you'll have fibrinoid necrosis. Rheumatic heart disease, Aschoff bodies will have fibrinoid necrosis, right? An extra point, if you answer very well, they might ask you this. Fibrinoid necrosis is highlighted by PAS and it will be reddish in color in PAS positive, fine? Last but not least, fat necrosis. Fat has two subdivisions. One is enzymatic, one is traumatic. Please don't confuse. If they ask you in a viva, what's a type of necrosis seen in acute pancreatitis? The answer is liquefactive necrosis, not fat necrosis. In acute pancreatitis, if they ask what is the type of necrosis in omentum, then the answer is fat necrosis because pancreas does not have fat. It cannot undergo fat necrosis. Peripancreatic, I have fat. Outside the pancreas, omentum, I have fat, right? So, in acute pancreatitis, the enzyme gets activated. One of the enzymes I'm more concerned here is lipase. Lipase destroys the peripancreatic fat, omental fat, causes necrosis. I mentioned here also, in the substance of pancreas, I'll have liquefaction, and outside the pancreas, I'll have fat necrosis. Second is traumatic fat necrosis. It will happen in any structure or organ rich in fat. Trauma, that's all. I hit my skin hard, my skin peels. I hit a tummy full of fat hard, fat gets destroyed. If you remember, insulin injection, lipodystrophy, fat necrosis, traumatic. I keep on putting injection here, it will traumatize the fat here. FNAC to the breast parenchyma can cause fat necrosis, right? So any trauma, breast parenchyma I can have, insulin injection I can have, abdomen, anywhere I can have fat necrosis. For some unknown reason, this is the place where Robbins talks about the saponification. When I have fat necrosis, I have necrosed fat, the free fatty acid along with the calcium, which is the most common ion in cell death, right? Both of them will bind and causes saponification. Saponification is a process which will happen in fat necrosis. But can I tell, I want everyone online to comment, can I tell by default every necrosis can have calcification? Thank you, Krish. Yes, no, maybe. What do you guys say? Yes, definitely. Though in Robbins it says that fat necrosis can have saponification or calcification. Any necrosis for that matter, the most common ion is calcium, and by default you will end up in having a calcification. And what is the type of calcification? Can we add one more question? Dystrophic or metastatic? Everything will have calcification, not only fat necrosis, right? Krish, Kaleem, every necrosis will have calcification. Fat, they've told it, that's all. And all the necrosis related calcification are called as dystrophic calcification. This is abnormal tissue. Papillary carcinoma thyroid is having calcification, some of my bodies, right? Same dystrophic calcification because papillary will die. Fine? As simple as that, right? So Robin says a concept. I don't want to read like 100 concepts. I read one concept applied in 100 places. That's all right. That's in short about necrosis. Fine, done. Okay. So we know the mechanism of necrosis. We know the subtypes of necrosis. We know the microscopic finding of necrosis, and also an application, clinical application, a reasoning why question. Why does the enzymes increase in cardiac death or your liver death? Right? Perfect. Now let's guys go to apoptosis. Again, before going to apoptosis, I'm going to ask you questions. You guys are going to answer. Fine. Simple questions, easy questions. I want you guys to answer. Can anyone tell me one physiological example for apoptosis? I'm sure pathological you tell. One physiological example for apoptosis. First question. Second question. There's one important enzyme involved in apoptosis. What's the enzyme's name? Kalim, samoma is a gritty calcification. Right? When it looks like a sand, I call it samoma. That's all. Calcification will be there anywhere. Doesn't mean that I should have samoma bodies everywhere. Fine. Okay. What they ask? The enzymes there, right? Third question. There are multiple places, easy ways I can identify apoptosis, right? There is one test especially, that is agarose gel electrophoresis. Can anyone tell me what is the pattern you see in agarose gel electrophoresis with respect to apoptosis? Great. Superb. Syndactily webbed feet are failures of apoptosis, right? It's not due to apoptosis. The webbing, I have 5 individual fingers. That's an example of apoptosis. If it's failing, I'll have syndactily. Okay, perfect. Thyroglossal duct, disappearance. I don't have it. That's apoptosis. But a person having a thyroglossal duct and a fistula is failure of apoptosis, right? Great, step ladder pattern. Fine. Okay. Afan, you should ask Pradeep sir, Pawar sir, and Pradeep Pawar sir, Vivek Nalgirkar sir, and Jambulkar sir for that. When you come to second year, we'll take care of that. Fine. Perfect. Now let's go to and see about apoptosis. Apoptosis is programmed cell death. 100% no student will ever forget. This is the equivalent of powerhouse of cell being mitochondria with respect to second year, right? It's a programmed cell death. Can be both physiological, can be both pathological. There is a huge number of examples. Anything in the body which I don't have, which is there in fetal tissue, is apoptosis. Notochord, classical example. The webs, classical example. The membrane around the eye, classical example. Thymus is apoptosis. Post-inflammation, the cells, neutrophils go outside. After inflammation, they don't come inside. They'll be dead by apoptosis. Excess ones, not the ones involved in inflammation. Fine. Perfect. Pathological, 3 important guys. DNA mutation, virus, most important is DNA mutation. Every virus will definitely cause apoptosis. And obviously, your intracellular protein. Intracellular protein accumulation puts the stress on endoplasmic reticulum and it triggers apoptosis. Yes, Kalim, you're absolutely right. In T cell differentiation, in the thymus, the lymphocytes, the self-reacting lymphocytes will be apoptosized, right? Krish, if apoptosis fails, I'll have the remnants of notochord, I'll have the thyroglossal duct, I'll have the webbed fingers, syndactyly and everything, fine? Okay. Hi Nitishri, come once you join, let's learn more. So I have phases of apoptosis. I have an initiator phase and I have an execution phase. In initiator phase, I have 2 important things, an extrinsic pathway and an intrinsic pathway. Extrinsic is outside the cell membrane mediated. Intrinsic is inside the cell, mitochondrial mediator, right? I have caspases there. I have caspase in execution pathway as well, right? First, we'll look at extrinsic pathway. Here, I have 2 important guys, right? The DNA mutation is the one which triggers the intrinsic pathway. The viral proteins is the one which will trigger the extrinsic pathway. You have to remember that, fine? Okay. Generally, I'm not saying it's always, generally that's how the dictum is, right? So when I have a virus dependent cell, lipodystrophy, it's me. Because of repeated injection, it's a traumatic fat necrosis which causes lipodystrophy, fine? See, this is not the right place to ask about that. Please don't spam. Please ask Pawar sir or Vivek sir or Jambulkar sir when he comes for first FARRE, fine? Thanks a lot. Okay, perfect. Let's come back to this. So normal cells have FAS receptor. It's a family of superfamily of receptor of TNF superfamily, right? So when a virus infected cell is there, the FAS receptor binds to its ligand, which is FAS ligand. This binding of FAS receptor and the FAS ligand, this is the other name, CD95. It activates a downstream pathway, which is FADD, right? Fast associated death domain. That's FADD. This FADD is the one which converts a procaspase. Every enzyme in the body is inactive form only. Converts a procaspase 8 or 10 to active caspase 8 or 10. 10 is a human caspase. most of the caspase are seen in tiny microorganisms like Drosophila, right? That's where we studied them. But 10 is something what we find in human. That's an example of a human caspase. This is what happens in, I'm going up, in the extrinsic pathway of the initiator phase of apoptosis. Now let's go look at the intrinsic pathway. To know the intrinsic pathway, I need to know normal. Once I know normal, abnormality is simple. In every mitochondria, yours, mine, I have balanced proteins, anti-apoptotic protein, which will not cause cell death. If a cell is not dying, the life of the cell will be long, right? So that's a mnemonic for us. Lifespan, longer life, L, L, L. If something has L in its name predominantly, it has a longer life, anti-apoptotic protein. Pro-apoptotic is backs and back. An exception of a mnemonic is this. BCL also has L, but S is there, it's a shorter life. Fine. And you have senses of cell stress, BIM, BIT, BAT, PUMA, and NOXA. So these are normal proteins present in the mitochondrial membrane. So when your cell is living properly, it does not have any stress, normal life, what will happen is this BCL2 will be very, very, very powerful. It will not let the cytochrome C go outside. That's a normal role of BCL2. The BCL2 does not allow cytochrome C to exit mitochondria. Can anyone tell me what's the function of cytochrome C? Only this part, Swarman. That's why biochemistry is important, to understand pathology and to understand medicine. Cytochrome C is required for electron transport chain. So if the electron transport chain needs to be functional, BCL2 should say, go inside, do the job. Only then I'll have ATP, only then cell will live. The moment I have a mutation, okay, mutation is one of the triggers of intrinsic pathway. The moment there's a cell stress or a DNA mutation, the cell is stressed, right? Okay, what will happen? Your senses of cell stress, BIM, BIT, BAT, PUMA, NOXA will increase. When the BIM, BIT, BAT, PUMA, NOXA increases, it has two jobs. One, it destroys BCL2, the one which is protecting my cell so far, and it will activate backs and back. The backs and back, what it does is, it activates and releases the cytochrome C outside the mitochondria. Normally, they were inside the mitochondria, giving me ATP. Now they come outside. So no ATP. At the same time, they don't keep quiet. They'll bind with one more protein called as APAF1. APAF, apoptosis activating factor 1. BCL2. Is me. The answer is BCL2. Fine. APAF1 will bind to it. So APAF1 and cytochrome C will form a complex called as an apoptosome. See, I'm again going back to your basics. Whenever you have some, S-O-M-E as a suffix, okay, it is not one protein, it's a combination of proteins. APAF1, cytochrome C forms a protein structure called as an apoptosome. What apoptosome does is, it does only one thing. Same thing what FADD did. Will convert a pro-caspase 9 to an active caspase 9. If you write this, that's enough to clear the exam. If you're aiming for distinction, I want you to add one more. Along with cytochrome C, there's a guy called SMAC and Diablo, which will come outside. When SMAC and Diablo comes outside, they will go and bind with something called an IAP, inhibitors of apoptosis. So they'll destroy the negative feedback also, so that apoptosis can go ahead and kill it. So this is the intrinsic phase of the intrinsic pathway of the initiator phase of apoptosis, right? I'll go back once again. So what we have done till now is, we know this and this. We have not led the execution pathway. Whether I initiate via cell membrane or mitochondria doesn't matter. It will definitely go downstream and it will cause cell death by execution phase only. And what's the execution phase? It's common for both. The caspase 8 or 9 or 10 will activate caspase 3 or 6. Once they are activated, I'll have cellular changes. The cell will shrink. One of the important difference between necrosis and apoptosis. They might ask you difference between necrosis and apoptosis. Don't go with any books. Think you will know more than what is given in books. Cell will shrink because all the caspase is a protease. All the cytoskeletal protein will be destroyed. Cell shrinks. Obviously, it becomes intense eosinophil because protein are destroyed. Endonuclease activation, not nuclease, endonuclease. As the name says, it's endonuclease activation. Fine. Okay. Suhas later, not now. Fine. I'll have an endocrine class. I'll explain that time. Endonuclease cuts in palindromic sites. It does not destroy the nucleus. Remember restriction endonuclease. So it will cause DNA fragmentation. Fragmentation results in condensed nucleus, heterochromatin, non-functional nucleus. That's all. So what I'll see finally is, I'll have a shrunken cell, intense eosinophilia, condensed nucleus with or without the material. That's what we call as an apoptotic body. That's a final outcome of apoptosis. I don't have cell membrane damage for the only reason here, I don't have activation of phospholipase. I have activation of only caspase, which is a protease, and endonuclease, which is a certain nuclease. Now the apoptotic body has come here. Someone has to remove them, right? So this apoptotic body starts giving signals, two important signals. One is complement proteins will bind to it, telling to my macrophage, see dead particle, opsonized, come and eat. And most importantly, phosphatidylserine and thrombospondin. These are seen exclusively in apoptotic bodies, not seen in inflammation. Complement is shared between inflammation and apoptosis. So once the apoptotic body comes, these go and bind on the surface. They eat me signals, phosphatidylserine and thrombospondin. Macrophage comes, eats it quietly. This eating is called an efferocytosis. This is not phagocytosis, this is efferocytosis. This is a modified phagocytosis where I don't have activation of inflammation because apoptosis does not have inflammation. Please remember that, fine? Okay. Morphological change, background inflammation will be there in necrosis. Apoptosis will not have it. Necrosis will be completely pink. Apoptosis will have apoptotic body which has condensed nucleus as well. These are few morphological changes in microscopy, fine? Perfect. So how do I identify them? You know how an apoptotic body looks? There are multiple places we see them. You must have read something called a Councilman body in hepatitis. It's an hepatocyte apoptotic body. Lichen planus is a skin condition. I have a structure called a colloid body or civet body. Again, skin apoptotic body is colloid body. Same apoptosis, different place, we call it differently. How do I identify apoptosis? One, microscopy. Shrunken cell, I'll have a nucleus. Without nucleus, the apoptotic body. Second, cytochrome C in cytoplasm, not in the mitochondria. Mitochondria is normal. If the amount of cytochrome C increases in cytoplasm, I'll definitely say it's apoptosis. Third is the one I asked you initially, agrosgel erythropoiesis. Two findings. If it looks like a smear, it's necrosis. If it looks like a stepladder, it's apoptosis. Again, a reasoning why question. Why do we have stepladder pattern in apoptosis? Answer is simple. Because in apoptosis, we have endonuclease activation, which cuts the nucleus, does not destroy the nucleus. When it cuts the DNA, I'll have multiple tiny molecular weights of the fragments of DNA, which is seen as a stepladder pattern in apoptosis. Smear, same. It's lysed completely. There's no single molecule. It's completely lysed as much, so you have a smearing pattern, right? Next, annexin stain. The phosphatidylserine came outside, right? That phosphatidylserine will bind to a molecular called as an annexin. I have annexin V, annexin 4, multiple things, right? Annexin is a stain, IHC stain, which binds to phosphatidylserine. So phosphatidylserine will be seen only in apoptotic cell. So annexin is positive only in apoptotic cell. And just name it tunnel assay. I'll tell you an example of what is tunnel also. Tunnel detects broken nucleus, broken DNA, that's all. Because you know that when I cut a DNA, the ends will be sticky. I use that property to identify, okay, this nucleus has sticky ends, so it's apoptotic cell. The nucleus does not have sticky end. It's a complete chromosome or the nuclear DNA, so it's a normal cell, right? That's the base of tunnel assay. Tunnel stands for, NEL stands for Nick end labeling, okay? Perfect. So these are ways I can identify apoptosis. I'll zoom out once again. Apoptosis, programmed cell death, right pathological examples, and phases. I have initiation, execution. Under initiation, intrinsic, extrinsic, bimbid bad bomb, fumanoxa, BCL2 backs back for intrinsic, extrinsic, FAS, ligand, FADD, and caspases. In execution, same, caspase 3 and 6 endonuclease forms apoptotic body, macrophage eats them with eat me signals and causes efferocytosis, and ways to identify apoptosis. Clear? Any doubt? If any doubt, do let me know. If not, we'll go to the next one. You're right, Krish. No. You keep commenting. I don't mind. Fine? Perfect. If it's a question, I'll answer. If you've written a fact, I'll ignore it. Fine? Can you go to the next one? If you're going to go to the next one, I want you to answer a few questions as usual. So we read about apoptosis, necrosis. We have multiple other types of cell death also, right? Can anyone comment on any other type of cell death you know? Apart from necrosis and apoptosis. Yes, it's me. You're right. Kaleem, I will have to take one more systemic pathology class, which most of you guys asked. I'll take it in my channel because PW will have more practical classes here. I'll definitely take it in my channel. We have necroptosis, we have pyroptosis, and we have ferroptosis. Pyroptosis can come in a 2 mark if your university has that, or in a Viva. Ferroptosis is not even worth for that, right? It's nothing. It's excess iron causing death. That's what is ferroptosis. Necroptosis can come in a short note. Possible for you to write because it has this unique mechanism. It has unique places where you see them. Yes, can come in a short note, but still it's smaller for a short note. 2-3 marks is definitely possible for us to come, right? So necroptosis is nothing but It's a regulated form of cell death or it's a regulated form of necrotic cell death. Generally, apoptosis is genetically regulated. Necrosis is not genetically regulated. But if I have a regulated genetic necrosis, that is necroptosis. It's a programmed cell necrosis. Fine. Then why we call it necroptosis? The starting point starts as apoptosis and ending happens in necrosis. That's why we have the term necroptosis. What's the exact mechanism? So let's say I have a virus. Necroptosis was first discovered in CMV. That's the first one is this, right? So I have virus. Okay. So virus came inside. My body said, okay, FAS, I'll attach with FAS ligand. I'll activate the protein, the FADD. FADD should supposedly activate caspase. But what CMV does is, it has an enzyme called as flippase. The flippase destroys FADD. So it's a mechanism of virus protection. Virus mutates, right? Same way, this virus said that, okay, this guy is killing me with FADD. Let me destroy FADD so that I can live forever. My body is not stupid. When virus COVID mutated, my body will react to it. So what my body did was, let me create a different complex. From FADD, instead of activating caspase, we activated RIP complex. The RIP complex activated a phosphorylated MLKL. MLKL is an oligomer, right? Multiple MLKL it's a protein like this. It will form, multiple of them will form something which will result in your pores. It will create pores in the cell membrane. Once pores are created in cell membrane is damaged, everything will come outside. You will have the same dams which will trigger inflammation and cause necrotic cell death, right? The only reason why I want you to remember MLKL is we have MLKL inhibitors in research. Because necroptosis is seen in very few classical conditions. It is classically seen in viral infection, few of them CMV. It is classically seen in steatohepatitis, neurodegenerative disorders, Parkinson's, multiple sclerosis, right? So inflammatory bowel disease. So we think that if necroptosis is the major mechanism, by creating an MLKL inhibitor, there's a possibility I can reduce the type of cell death or inflammation in the above said condition. That's the reason we need to know about necroptosis. That's about necroptosis. Fine. Okay. Done. Then your pyroptosis. Pyro is fever. There are few important keywords in pyroptosis which should be there in exam. Pyro is an inflammatory form of programmed cell death. It's an inflammatory form of apoptosis. The most important trigger for pyroptosis, intracellular pathogen or uric acid. Uric acid is also an intracellular abnormality, right? So whenever I have intracellular pathogen, bacteria or virus or uric acid, there's an activation of a complex called as inflammasome. Okay. Once inflammasome is activated, right, NOD-like receptor binds to it and activates them. Inflammasome, it activates caspase 1. It's an interleukin beta converting enzyme. Okay. That will increase interleukin 1. At the same time, it will activate other caspases, caspase 4 and caspase 5. When interleukin 1 is more, it's an acute phase reactant, right? It will cause fever, inflammation. Caspase will cause death of the cell. It's an intracellular organism. The best way to kill them is kill the cell. They cannot survive outside. So the organism dies, right? So it causes apoptosis, classical apoptosis. In addition to that, because of the activation of interleukin 1, I'll end up in having fever and cell death. Fever is pyro, right? Fire. So we call it pyroptosis. That's all. As simple as that. Fine. Okay. This is the basics behind gout will trigger lots of interleukin 1. If you remember gouty arthritis treatment option, there's an interleukin 1 antagonist which is useful for treating gout. Can anyone name the interleukin antagonist? Since you have completed pharmacology also, let's see how good your pharmacology is, right? Mine is not great. I hope yours is good, right? Perfect. Then I'm not going to talk about ferroptosis because ferroptosis is nothing but normal iron. If I have a normal quantity, my body has lots of antioxidants to take care of that. It will not cause activation of reactive oxygen species to cause cell death. But if iron exceeds beyond a certain limit, it will deplete the intracellular glutathione. That's one of the antioxidant and it will cause more reactive oxygen species and it will cause cell death. As simple as that. Fine. Perfect. Have you heard about the drug called as anakinra? Have you? Yes, no, maybe. Okay, anakinra is an interleukin 1 antagonist. I think I'm right. If not, please correct me. That is useful in acute gouty arthritis. Fine. Perfect. Now let's go to intracellular accumulation. See, intracellular accumulation can come in an MCQ or a Viva. Worth asking for a short note or a 2-3 mark question is fatty change or your calcium accumulation. Your pigment change, very unlikely to come as short note or a 2 mark, or your protein accumulation, yes, can come in a Viva, can come in an MCQ, not for an essay question or a short note. Fine. So now we look at fatty change and also look at your calcium degeneration here. Fine. Fatty change, you know the fatty change. We have read about fatty liver also. See, please, when your question comes in first paper of fat accumulation, do not restrict yourself from the first part of Robbins alone. If you know few pointers which make sense from systemic pathology, use them, because general pathology is a base. Once you have completed Robbins, you can add lots more to them to make lots more sense. Fine. Etiology of fatty liver. The one of the most common etiologies, increased consumption of fat. You keep on eating junk food, it will go and definitely get deposited there. PM, especially in children, where the peripheral conversion comes to the central pool, right? Because lots of muscle damage, fat wasting will be there. Everything comes to the liver and gets stored in the liver. Toxins. Carbon tetrachloride is one of the toxins which causes fatty liver. There are many other toxins which can cause liver damage. And anything which causes liver cell damage. Liver's function is to produce fat or metabolize fat. If liver is damaged, fat also will not be there. That's what we read in necrosis also, no? One of the changes, fatty change. That also can cause. All these can cause increase in deposition of fat here, and these fats are triglycerides. There are two things in fatty change. One could be triglycerides, other could be cholesterol. Cholesterol and its esters. Fine? Okay? Yes, it's me, right. So when this fatty change, grossly fat looks yellow in color. So the organ looks greasy, yellow and enlarged. Fatty liver. Microscopy, fat is clear. This is a very good reasoning why question. And also you can have in Viva. Why is fat clear? Because we know the answer without a doubt. Fat will be washed away during processing because we use alcohol in processing. Alcohol washes away the fat. Alcohol washes away grease, right? Simple. Colon removes the grease. It's fat. Alcohol dissolves fat. Same thing happens in microscopy. The fat will be washed away, so I'll have an empty space. That's the reason fat is clear in microscopy, right? Can come in a reasoning by question. Please do remember. Fine. Okay. So fat appears clear, and obviously when something is clear, I need to write the stains for fat. You have Sudan black and oil rideau. These are perfect stains for fat. But since fat is clear in microscopy, for doing fat stains, I need a frozen section. I cannot do fat stain in normal section. I have to do only in a frozen section. That's all. As simple as that. Fine. Perfect. Okay. So the second part of fat accumulation is cholesterols. It's not only triglycerides. In liver, there's triglycerides. In atherosclerosis, do you have triglycerides or cholesterol? What do you have? We have cholesterol, right? We have cholesterol in atherosclerosis, right? So fat deposition can also be in heart. We call them a tigroid heart because we have layers of fat. You have the yellow layer and the normal heart. Yellow layer and the normal heart looks like a tiger or a tabby cat appearance. Cholesterol can also get deposited. Cholesterol esters can also get deposited. The best example is strawberry gallbladder. Cholesterolosis, atherosclerosis is one example. You have your Niemann-Pick disease, the fat accumulation, all the lysosomal disorders, where there also you can have the cholesterol accumulation, right? So you have strawberry gallbladder for cholesterols, and this very rarely tabby cat appearance, not so important, but that's also triglyceride appearance, accumulation, fine? That's about fatty change. The next is my favorite topic in the entire pathology is calcium accumulation. Sometimes when you read books, it should stimulate you that, okay, medicine is easy. Medicine is not something which you have to memorize. The best example for that is fatty change, is your calcium accumulation, right? Listen to me carefully. I'm going to explain it a little bit more than what I used to do in FARRE, because if you're even reading it for the first time, it should make sense that medicine is really easy. Calcium has two types of accumulation: dystrophic calcification, metastatic calcification. Meta means change. Stasis means homeostasis. Whenever there is disturbance in calcium homeostasis, which increases the calcium level in the body, that is hypercalcemia. Calcium will deposit, there is no doubt in that. So what causes hypercalcemia is my etiology. Hyperparathyroidism, because parathormone metabolizes calcium. Chronic kidney disease, because kidney eliminates calcium. When it's failing, I will not be able to eliminate calcium. Rapid bone resorption. Bone is the richest source of calcium, right? I have multiple myeloma, punched out lesion, rapid bone resorption. Metastasis, rapid bone resorption, right? So whenever there is excess of calcium due to above said etiology, this calcium has to deposit. This calcium is in the bloodstream. It cannot deposit in aorta because it's very fast flowing blood. It cannot deposit there. If you've seen a river, always the sand will deposit in the beds of the river. Same way, the tiniest place, that is capillary, is the place where calcium can get deposited. The most common is in lung, because lung is the organ which is rich in capillaries. The next is kidney, glomerulus, rich in capillaries. It'll have deposit in GAT, not because of capillary. GA has bicarbonate. Calcium, bicarbonate deposits. Salt, now it becomes heavier deposits. Calcium is a very important neurotransmitter in the brain. It will cause agitation, anxiety, irritability, psychiatric disturbances. If you have read Robinson hyperparathyroidism or in your medicine or surgery postings, they must have told this mnemonic. Bone pain, resorption, abdomen groans because of calcium will cause constriction of the muscles. Psychic moans, neuropsychiatric defects, kidney stones, classical for hyperparathyroidism. That's all about metastatic calcification. I need to remember metastasis. The same way dystrophic. Dys means abnormal. Dysphagia, dysmenorrhea, dyspareunia, right? Dys means abnormal. Trophy is cells, tissue, hypertrophy. Abnormal tissue causes dystrophic calcification. What does abnormality mean? It could be either degeneration, old age is abnormal, right? Or a dead tissue. Degenerated tissue, best example is cardiac valve. Your cardiac valve, my cardiac valve, when I hit 60, you will have calcification and blood vessels. Now, it asks me question, why these two alone? See, because remember, these are the only two places, every single minute of my life, it's getting hit. Heart pumps every single minute. The same blood goes via blood vessels. It's been hit every single minute. My skin, my finger does not move every single minute. But this guy moves every single minute. So the chance of damage is more. Whenever there's damage, what's the most common ion? Calcium. Calcification is more. And dead tissue. Dead tissue is where you must have read about Samoma bodies. You must have read mnemonics for Samoma body. No need mnemonics at all. It's beautiful pathology and science. Any lesion which is papillae. Papillae is a finger-like projection with a central fibrovascular core. Look at the tip of the papillae. Less blood supply. Ischemia, infarction, cell death, necrosis, most common in calcium, calcification. Papillary carcinoma, thyroid, breast, kidney, serous, ovary, pancreas, anywhere. Because serous means microscopy will have papillae. Second is these two guys. These two guys have a pattern called as a whorled pattern. So whirling, center of the whorl will not have blood supply because blood supply comes from the outside. Center of the whorl, ischemia, infarction, necrosis, calcium, calcification. That's all. So any tumor which is papillae or whorled pattern in microscopy is bound to have Samoma bodies. That's all. Dystrophic calcification, this means abnormal, degenerative, dead tissue. Now calcium is bluish in color. So I might sometimes find it difficult to identify. So what do we do? Special stain. I have two stains, one cosa, alizarin red. Okay, they had a mnemonic for it. Everyone in pathology lab knows this. KAL, cosa and alizarin red, right? Instead of calcium, we call it calcium. Cosa is the most common used. One cosa, cheaper. Alizarin is very specific, expensive. We don't use them, right? That's how calcification looks like. That's how a Samoma body looks like. It's whorled calcification seen in meningioma and leiomyoma, right? Okay, fine. That's simple thing about calcification. If any of your friends hate medicine, ask them to read that. Just calcification. It will open their mind that medicine is not about memorizing. Medicine is about understanding. You understand dystrophic, you understand metastatic, and when you grow, when you read medicine, general medicine, surgery, OBG, look at the terms. The terms tell a story which you're not understanding. That's why we memorize and we want shortcuts. Otherwise, no need for shortcuts. Medicine was not created with mnemonics, right? When people wrote books, they never knew facts. They never knew mnemonics. They wrote books because they liked science. And this is how science will be. Fine, perfect. These are the two of the intracellular accumulation which can come in an exam. Fine, done. So we've seen adaptation, we have seen necrosis, we have seen apoptosis, we have seen intracellular accumulation, necroptosis, pyroptosis, and ferroptosis. Right? Then we'll go to aging. I don't know if they'll ask in an exam, but if they can ask, worthwhile asking an essay question because there are multiple theories of aging, and yes, it's definitely worthwhile asking exam. Right? No one likes to age. And obviously, we have to learn about aging as well. So what is aging? Aging is not growing old. Aging happens at cellular level. Yes, when I grow 60, I age. But my cells can age much faster than me, right? Aging is nothing but whenever the cellular function and the viability declines progressively, that's aging, right? That's all. You must have had gray hairs. Your parents might have gray hairs. That is aging. That's it. This cell is declining in the progression of producing melanin. That's aging. That's all. Aging is cellular aging. I'm not talking about a human being age. And we talk about the theories of cellular aging. When the cells age, automatically the organism will age, right? We have senescence, DNA damage, defective protein regulation, and the latest one is dysregulated nutrient signaling. And that's the most important because most of us age because of dysregulated nutrient signaling primarily, right? What does senescence mean? See, anything in my body or in the world, when it grows older, which will lose some of its potential. Two important reasons for cellular senescence. One is telomere attrition, right? I'm sure you must have known about telomere attrition. You must have read about telomeres in your biochemistry. Every cell, with every cell division, the terminal part keeps on shrinking. That is telomere. Hayflick said that a somatic cell can divide 80 times. Beyond that, it cannot divide. That is telomere attrition, right? Obviously, beyond a certain limit, the cells cannot divide and they will undergo death. When they die, in a tissue, I have 100 cells. 50 cells die. Function will decline, it will age. That's all. There are exceptions for everything in the world. Germ cells, stem cells in my body don't die because they don't have telomere attrition because they have an enzyme called as telomerase. Whenever it shortens, it becomes bigger. I'll come to it, Kalim. I'll come to it later. Whenever it shortens, it becomes bigger with the help of telomerase enzyme, right? These are exceptions for your cellular senescence, right? Second part of cellular senescence is P16 activation. P16 is a cell cycle inhibitor. It will stop the cell division from G1 to S phase. So whenever the cells become smaller and smaller and smaller, not able to divide, P16 will come and say, see, your time is up, don't divide, you can't divide. So telomere is the starting point. It will activate P16 and say, you can't divide, so you will die, no one will be able to replace you. The cell dies, function declines, organ reduces the function, and the entire person also ages. That's a first theory of cellular aging, cellular senescence. Second is defective protein homeostasis. Normally, I have a hemoglobin. This hemoglobin has got its life. Everything has got its life. When this hemoglobin is not formed properly or it's become old, damaged, I have a system called as a ubiquitin tag. Ubiquitin comes and gets stuck to this. So whenever a protein has ubiquitin tag, I have a pathway called as proteasome. It's like a machine. It will know that, okay, this is ubiquitin tag, I should destroy them. They'll destroy them, split them into amino acids, and they will be reutilized. This is normal recycling of proteins in my body. But let's say if I don't have this ubiquitin tag, I'm not able to tag with ubiquitin, or the proteasome pathway is not functioning properly, dysregulated protein. So what will happen? It will start accumulating inside the body. Like mutation starts accumulating inside the body. If you remember apoptosis, I said that more and more protein accumulation inside the body, it will trigger endoplasmic reticulum stress and it will cause apoptosis. So whenever I have lots of malformed protein which is not being able to remove with routine mechanism, it will accumulate, cause stress in the endoplasmic reticulum and will kill the cell. That's apoptosis, fine, right? Perfect. Third is DNA damage. You have mutation, by default, P53 will come and say, boss, you have a mutation, I will kill you, otherwise I'll repair you. If I can repair, I'll repair, otherwise I'll kill you. This is how normally it happens. Question is, who causes the mutation? Yes, you will say that radiation causes mutation. More than radiation, I have multiple other things. That's where your topic of reactive oxygen species come. This alone can be in a 5-mark question. Okay. So mutation, one of the important cause of mutation is not a carcinogen. It's there in my body, reactive oxygen species. That's the most common cause of mutation, right? So reactive oxygen species is nothing but an unpaired electron. Going back to your chemistry. In the outer orbit, I have an extra electron which can bind with anything and cause a reaction. That is reactive oxygen species. Who creates them? Cellular respiration creates them. What's the outcome of electron transport chain? Reactive oxygen species. Every molecule of ATP I produce, I'll have reactive oxygen species. UV rays, you can't be there without UV rays. It'll cause, it's a radiation, right? It'll cause reactive oxygen species. Drugs can cause inflammation. It'll cause, because all the WBCs, they produce reactive oxygen species. Free metal ions, you must have remembered, free iron is dangerous, free copper is dangerous because they create reactive oxygen species. It's not that I'm going to die with this because I'll have mechanisms for me to stop it. That are the antioxidants. I have these antioxidants, the non-enzymatic are the one which we generally focus on. Let's eat more vitamin A, vitamin C, I'll become younger. No, it is useful. I'm not saying it's not useful, but I am born with enzymes. Every cell in the body has enzymes. I have catalase, superoxide dismutase, which removes superoxide is O2 minus, it converts them and destroys them. Two subtypes, manganese and zinc dependent. Okay, fine. So I think it's, just check this. Manganese is mitochondrial. Thing is copper dependent or zinc dependent. Just check that once, right? And we have glutathione peroxidase, right? All these are enzymes which are present inside every cell, which will help me to destroy the reactive oxygen species. What are the reactive oxygen species? OH minus, one of the most common reactive oxygen species, most potent free radical, and I have HOCl, hypochlorous acid, which we'll read in inflammation chapter, which kills bacteria. It does not kill me much. It will kill bacteria for sure. Hydrogen peroxide, yes. Superoxide, yes. Peroxynated, especially in inflammation, because nitric oxide is one of the components of inflammation, right? So what will these do? If my production of reactive species is more than my ability to destroy them, this can kill my cells or cause mutation in cells, which can age my tissue. If the production is normal, the way I can remove it, no problem at all. Whenever the production becomes more, I'll have a problem. What way I can have a problem? It can destroy the lipid, cell membrane will be damaged. It can damage the protein, it can damage the DNA. In short, it will cause necrosis, that's all. It will cause cell death. So I have to make sure my inflammation is the bare minimum. You must have definitely heard this without fail. Stress is one of the important factors for aging. How many of you have heard this? You must have heard this, right? The reason is stress increases reactive oxygen production. When ROS increases, by default, you're going to age, right? This is one of the known and one of the important mechanisms why we age faster. The last one, Kalim, you asked me what is dysregulated nutrient signaling. One of the most important contribution of reactive oxygen species, my mitochondria producing ATP. So imagine, normally I need 10 ATPs to live. So I have 10 reactive oxygen antioxidant to nullify that. But I'm eating junk, eating more than what I want. My body is producing 100 ATPs. So 100 ROS comes. I have only 10 antioxidants, 90 will destroy me. So whenever a food intake increases, dysregulated, not stopping, junk is good, junk is tasty, let's pop in an entire bottle of Coke. I have a problem. I'll have more reactive oxygen species. Not just that, it will activate insulin-like growth factor, it will increase cell division and accelerates aging. It has two ways of accelerating aging. One, producing reactive oxygen species and destroying it. Second, like I said, every cell has 50 times cell division to 80 times, that's all. So I can slowly divide like this or give the energy and fastly divide like this. With insulin-like growth factor, the cell division accelerates. So obviously, the lifespan reduces. In two ways, excess eating will cause aging. Yes, not always food is bad. There are few types of food called as serotins, which is there in red wine, grapes, and few of the food products, which is nothing but an deacetylase. It's an enzyme, that's all. So it's an NAB-dependent deacetylase, which reduces metabolism, suppresses aging, and aging-related disorders. Serotonin reduces the risk of coronary artery disease, diabetes, cancer, and slows the process of aging. Doesn't mean that you have to go and drink red wine, not at all. It's a molecule present. Is it useful in real life? Really not useful. It's more theoretical and less practical. As on date, in future, I don't know what will happen, right? So all these are theories of aging, okay? So we have serotins, we have free radicals, you have your defective protein homeostasis, you have your DNA damages, and you have your cellular senescence, right? And if it's asked in a long answer, I want you to add a single word about the disorders. Talk about progeria. I'm sure you know what is progeria. You must have seen the movie Pa, right? Hutchison-Gilford progeria, where you have LMNA mutation, which codes for lamin protein. Lamin is present in the nuclear envelope. So once it's gone, nucleus is not stable, accelerates faster. Second is, we have a syndrome called as Werner, N, not M. Okay, Werner syndrome, where I have mutation in helicase. Helicase is required for the replication fork formation. So when helicase is not there, the DNA will not unwind and the cell cannot divide, right? These are two disorders of cellular aging or a premature aging, progeria and Werner syndrome, right? Write this if it's a long answer. Short answer, those 5 theories are more than enough. Just remember the name and write there are disorders of cellular aging, which is progeria and Werner syndrome. Fine, done. So we know about the cellular aging as well. So we completed most of the things required in first chapter. Can we quickly go to inflammation? I'm sure you know many things about inflammation. Okay, inflammation again, will they ask in a long answer? I won't ask because it's pretty basic. Chronic inflammation I can ask in a short answer, granuloma formation. But where is inflammation actually useful is to understand systemic pathology and hematology, right? This selectin, rolin, you never have any application of selectin or rolin, right? except for few inflammatory disorders. Okay. First thing, we look at acute inflammation. If at all someone is going to ask you a very dry theoretical topic, yes, they might ask this. We have phase of acute inflammation. You have vascular phase, we have cellular phase, and obviously every inflammation will resolve by either clearing the inflammation or causing tissue damage. First, vascular phase. So I have a vessel, a normal vessel. In a body, vascular and cellular happens together, but for understanding, we separate and learn it. First event is histamine associated vasodilatation. So when the vessel dilates, normally the vessel have laminar flow, smooth flow with the cells in the center and the plasmas in the corner. But the vasodilation causes turbulence. The turbulence is the one which pushes the WBC to the corner. It marginates to the corner. Normally they were in center, now they have gone to the corner. It's primarily a vascular phenomenon, but a molecule called selectin helps to hold them in the corner. They should not come back to the center, right? They'll be held in the corner with selectin. That's the first step, margination. Second is, they have come to the corner. They have to go outside. That's increased vascular permeability. Hallmark of acute inflammation is vasodilatation and increased vascular permeability, right? So there are multiple mechanisms of increased vascular permeability. The new Robbins does not have this, but if you want, you can write it because they are very easy to remember. I have something called an immediate and transient, immediate and sustained, delayed and prolonged, permanent inflammation. These are 4 mechanisms. Immediate and transient, a mosquito bite. I have itching for 10-15 minutes, I forget after that because the stimulus is very, very tiny, right? Or an ant bite, because this is completely mediated by a molecule called histamine. Histamine is the runner here. Histamine's half-life is very short. It lasts for only 10-15 minutes. You will forget about it. Immediate and sustained, maybe for 10-12 hours, I'll have the stinging sensation. Cooking related burns. If you are cooked or your mom was cooked, suddenly you touch a hot vessel. Don't keep on holding for long. Suddenly you touch. Tiny swelling, tiny boil will be there. Classical. Because why it's sustained is, it's not chemical mediated. I'll have endothelial damage, direct endothelial damage. I need some time for endothelium to heal, right? So 2 to 12 hours. Delayed and prolonged. The best example is UV related. You go out in the sun today, you won't have sunburn today. You'll have after some time only. Because the sun, UV rays causes mutation. Mutation causes damage. Damage then heals. So it's indirect injury, not direct injury. That's why it's a delayed onset. Every UV ray, every radiation exposure, delayed onset only. Permanent is extremes of input, severe burns. You put your hand into the person has burns. Entire thing is gone. So what happens there? It's irreversible. It's irreversible endothelial injury, and every irreversible injury minimum requires a week to heal. 5 to 7 days to heal or to have a new vessel formation. So but till that time, inflammation will keep on having that, or the vascular permeability will leak till that point of time, right? So these are 4 patterns for increased vascular permeability. This is a vascular phase. I have dilatation because of histamine, and increased permeability changes because of the stimulus. What are the stimuluses? I have a different mechanism for increasing the vascular permeability. So now the gates are open. What's the next job? The cells should come outside. The only way cell can come outside is the mechanism of rolling, addition, diaphoresis, then goes outside, goes to the bacteria, eats, then destroys them. That's what happens. These are steps of cellular phase. You definitely will know rolling, addition, diaphoresis, right? We have selectins, Cialis X for rolling. We have integrins, CAMs for addition. Okay. So we have Cialis X, which is there on the WBC. We have integrins, which is there in the WBC. You have to know which is there in the WBC because that's required for understanding disease. Okay. So whenever you're normal, these are not expressed in the body. Only when you have interleukins. Interleukins. That's the one which will make my selectin or Cialis X more prominent. Otherwise, they're not prominent, they won't stick. Once I have inflammation, these cytokines and interleukins activate them and they bind. This binding is a weak bond, so blood detaches them, right? So blood detaches, goes, rolls. Second is addition. Wherever I have had the increased vascular permeability, the gap in the endothelium, that's where I have to stop. I cannot roll over that, right? I'll start stop. For that, I need integrins. This is a very firm, this is a strong bond, right? It's a strong covalent bond. It's strong bond. It's strong, and the WBC and the endothelium does not move beyond this. It stops there. What's the next step? I have to go outside. But I have a problem here. I cannot just like that go outside. I have only gapped the endothelium. basement membrane is still there, right? So what do? So in dialysis, two-step process. The first step, with the help of a molecule called as PCAM, platelet endothelial cell adhesion molecule, or CD31, the WBC escapes outside of the endothelium. The next, I have basement membrane made of collagen. WBC degranulates, releases non-specific collagenases, puts tiny holes, does not rupture, puts tiny holes, goes outside through the holes and comes outside, right? That's a way I'll escape from the blood vessel. Once I come out of the blood vessel, I have to know where is my bacteria. How do I know? Chemotactic factors. Chemotactics is purely based on chemical signals. Your actin will get polymerized, the cells produce pseudopod movements and move to the site of the bacteria. I have endogenous and I have exogenous chemotactic factors. You know more about them. I'm not talking about them much in detail. So I recognize them with the help of receptors, toll-like receptor, nod-like receptor, and I eat them, which is phagocytosis. The moment I eat them, then I'll have to kill them. I have two mechanisms of killing. Non-oxygen dependent or oxygen independent is a very weak mechanism, because the granules of WBC will have lactoferrin, few antibacterial properties that will kill them. Not effective at all. The best form is your oxygen dependent mechanism, or we call them respiratory burst. It's oxygen dependent. So the primary player here is oxygen. I have oxygen. With the help of an enzyme NADPH oxidase, I produce superoxide. Whenever there's superoxide dismutase comes, I produce hydrogen peroxide. If hydrogen peroxide is there, along with MPO and chlorine, it produces HOCl. This is very common in neutrophils. The same hydrogen peroxide is there with MBP, which is major basic protein, and iodine, produces HOI, which destroys parasite. Okay, it will destroy parasites here. So one is there in eosinophil, one is there in neutrophil. Ultimately, I'll be destroying them. This is a very efficient method. I've been successful. If I'm successful, should I stop the rolling addition? Should I stop the leakage of blood vessel? Yes, that's resolution. Neutrophils will work for 24 hours maximum. They also have a time. If they fail, macrophage will come and say, you're useless, go outside. If they're successful also, macrophage will come and say, you've done a good job, let me take care of it. So once neutrophils kills the organism, macrophage comes, removes everyone, and the macrophage starts releasing anti-inflammatory cytokines, which are your interleukin 10, your resolvins, right, and lipoxins. All these are anti-inflammatory products, which will say that, okay, inflammation is enough, let's stop it and let's take care of the rest, right? These are the simple steps of inflammation, right? I know this is monotonous. You have definitely known that. It's just a recap to see what's happening there. Actually, what is important for me is not the steps of inflammation, because that's normal. We learn pathology. We like abnormality, right? We have disorders of acute inflammation. When this rolling addition is not happening, my WBC cannot go outside, cannot kill them. We call them, see, the word is important, leukocyte adhesion deficiency. So the problem is in the leukocyte, not in the WBC. Fine, please do remember them, right? So here, so you have LAD1, LAD2, LAD3. LAD3 is rare, ignore them. If you can write. LAD1 is integrin. One looks like I, right? It's integrin's defect. Fine. Because integrin was there on the WBC. LAD2, 2 looks like S, right? So CLL-Lewis defect. If you invert it, looks like an S. CLL-Lewis defect. There is CLL-Lewis defect will destroy the selectin process, so the rolling process. Your integrin will destroy the adhesion process. Both will be having recurrent infections. In addition to that, your integrin defect will have delayed umbilical cord separation, because integrin is very, very important for wound healing. Selectin defect or CLL-Lewis defect will have Bombay H group, because CLL-Lewis is very important for the blood group. That arm is important for A or B. When the arm is not there, I'll have no blood group, no A or no B, not even O, it's H group. Fine. Both of this will have, the most important thing is neutrophilia. Again, I can have reasoning why question. See, generally, when you have an inflammatory disorder, right, or a recurrent infections, immunodeficiency disorder, we expect neutropenia, right? That's what is immunodeficiency. But this is one immunodeficiency disorder where I'll have neutrophilia. Why? The reason is simple. These are not problems of WBC's absence. The problem here is WBC is not able to go outside. So where will they stay? They'll stay inside the blood. So the amount of WBC inside the blood will keep on increasing, but the WBC will not be there in the site of infarction. That's why I have neutrophilia in case of leukocyte adhesion deficiency. Clear? Perfect. Next is chronic granulomatous disease. Name is simple. Acute inflammation failed, so everything became chronic, and every chronic inflammation will have granulomas. Chronic granulomatous disease. So we have X-linked recessive disorder and autosomal recessive disorder, because there are two types of NADPH enzyme. When NADPH is absent, the entire respiratory bus will not function. When the respiratory bus will not function, my body cannot clear the microorganisms. I end up having chronic inflammation, right? Because no HOCl, no respiratory burst, no HOCl. When there's no HOCl, by default, I cannot kill them, right? How do I diagnose them? Is there any classical clinical features? This is a very important feature. You'll have infections by catalase positive organisms. This could be a clue in an MCQ. Purely catalase positive organism infections, think of chronic granulomatous disease. This is a thing for CGD. Okay. I have tests for them. I have dihydrorhodamine test, nitroblue tetrasolim test to diagnose them. And also sometimes you can even assay the NADPH enzyme and say it's less, not present. It's a chronic granulomatous disease. The catalase positive is a very, very important clue. Remember them. Last but not least, the celiac AR syndrome, right? Celiac AR syndrome, I have a problem in both will be there, Shia. Okay. In celiac AR syndrome, I'll have a problem in the gene called as LYST gene. LYST stands for lysosomal transporter. Autosomal recessive disease. I'll have problems in movement of lysosome. When the lysosome does not move, I cannot have phagolysosome. If the phagolysosome is not happening, respiratory burst will not happen. So what happens here? I will eat the organism, phagocytase, but I will not have lysosomal fusion. So instead of destroying them, the organisms will go into my WBC and keep on dividing. That gives the giant granules. So these giant granules in celiac AR syndrome is nothing but surviving bacteria inside WBCs. That's all. You can see them classically in microscopy like this. Giant granules in the WBCs. Diagnosing specific finding for celiac AR syndrome. The thing about celiac AR is not about the infections. That will always be there everywhere. What is unique is this LYST does not help only in the movement of lysosome. It helps in the movement of melanocytes from the neural crest till my fingertip. It helped in the movement of Schwann cells from the neural crest till every peripheral nerve. It helped in the movement and the change in morphology of platelets. So when LYST is not there, no Schwann cells, no peripheral nerve myelination, peripheral neuropathy. That's a classical finding. When LYST is not there, melanocytes cannot come to my fingertip, no melanin production, albinism, classical finding. When LYST is not there, platelets are present, but platelets cannot function. That is thrombasthenia. Asthenia is reduced function. Myasthenia, muscle is there, function is not there. Thrombasthenia, platelets are there, function is not there. And this is more than enough for me to identify a classical specific finding, granules in the WBC, diagnostic of celiac AR syndrome. If required, I can do a genetic diagnosis also. Fine, perfect. So that's about the disorders of inflammation. So we read about quick review on acute inflammation and its disorders. Okay. Any doubts? If not, let me know. Can we go to the next topic? Next about simple guys, chronic inflammation. That's all. I'll ask you questions on chronic inflammation. I want you guys to answer. Then we'll go to chronic inflammation per se. Fine. What is the prototype of chronic inflammation? Everyone online, answer. Simple questions. TB is a prototype of chronic inflammation, right? What is the microscopic feature of classical chronic inflammation? Whatever comes to mind. Sure, next gen come. Kaleem, platelets don't generally move, right? They are in the blood, which helps in the movement of the platelets, right? So for platelets, it's a conformational change. The phospholipid has to come outside. Those conformational changes what affects in platelets. Normally like this, you can call this as movement of platelets, the morphological change. Fine. Great granulomas. Can anyone tell me one example of non-necrotizing granulomas? One example of non-necrotizing granuloma. If you answer sarcoidosis, I'm happy, but internally it's a bit sad for me because if it's non-necrotizing granuloma or necrotizing granuloma, my first diagnosis should be tuberculosis. TB is always the first diagnosis. Yes, sarcoid. Yes, foreign body. yes to every other thing, but TB is still the first diagnosis for both necrotizing and non-necrotizing granuloma, right? Last but not least question. We'll go to the topic soon. Can anyone tell me the name of the giant cell in tuberculosis? A very easy question. I'm sure you know that. Name of giant cell in tuberculosis. Name of giant cell? Langerhans giant cell, right? Perfect. Now let's go to chronic inflammation. Chronic inflammation is simple. If the disease is going to last for more than few days to weeks, prolonged duration, persistent inflammation, it's chronic inflammation. I have been telling this year long and I'll tell this lifelong as well. The hallmark of chronic inflammation is TDHF, tissue destruction, healing by fibrosis. If you remember this, trust me, half of pathology is done. It's just application of TDHF is what differs. Tissue destruction and healing by fibrosis is by default the mechanism of chronic inflammation. And the cell of chronic inflammation is macrophage. Not just normal macrophage, also one more guy called as an activated macrophage. See, everyone has two levels, right? Normal and more. This is same. Macrophage will eat. Activated macrophage does not eat. They will secrete. I have two types of activation, M1 and M2 activation. This is basics, then we'll go to the rest. Whenever I have microbial products, lots of lipopolysaccharide and interferon, a normal macrophage becomes an M1 activated macrophage. What's the role of them? They will promote killing of the organisms by increasing lots of interleukin secretion. See, the function is not phagocytosis, function is secretion. So our ultimate goal is, I'm not able to kill this guy with a tiny bomb. So I create more and more and more in power and I put an atom bomb and kill them. That's what M1 activated macrophage does. M2 or an alternate active macrophages will be there when a normal macrophage is exposed to interleukin 4 or 13. The job here is also secretion, but not interleukins. They secrete VEGF, they secrete TGF beta. I'll help them in wound healing. VEGF produces blood vessel, vascular endothelial growth factor. It helps in the production of neovascularization, granulation tissue. TGF beta produces fibroblast and collagen. This is anti-inflammatory and reparative, and this is pro-inflammatory. So I have two pathways of activated macrophage, right? Now let's come to the pathogens of granuloma formation, right? Granuloma should not be forgotten at any point of time. TB should not be forgotten at any point of time. You forget Marfan syndrome, BRCA and BRCA gene, doesn't matter. You cannot forget granulomas. TB is amazing. My body said that I had a macrophage and the most powerful guy here, I can destroy anything. TB went inside there and said, TB will survive, not only survive, they will divide inside the macrophage. Macrophage got pissed off. Can't do anything. So what do? Macrophage is also an antigen presenting cell, right? If they can't do something, they will say, T cells help me via MHC2 complex. Then the T cells came and said that, okay, don't worry, I'll help you. I know three ways of activation, TH1, TH2, TH17. Okay, you are granuloma. Let's go to TH1. Allergy, TH2. Acute or chronic, TH17. Right? So it goes to TH1. This TH1 secretes interferon gamma. Where did we read interferon gamma? Interferon gamma can convert a normal macrophage to an activated macrophage, right? So this interferon gamma will convert normal to an M1 activated macrophage. Activated macrophage secretes more powerful reactose species to kill the TB. They said that, okay, maybe it's not enough for me if I act alone. Let me call more people. So what they did was, they increased interleukin 1, interleukin 12 and multiple others. Interleukin 1 brought more T cells. Interleukin 12 pushed them to TH1. TH1 produced interferon. Interferon produced macrophages, more reactose species. It's a vicious cycle, right? It's one of the beautiful things. I don't know what to do. I'll think, I'll learn, I'll improve. That's what my body taught us. That's what I want you guys to do. There's no end to questioning. Question more, learn more, become excellent. Simple bacteria. Look at the loop. I need T cells. I produce interleukin 1, brings T cells. T cells can differentiate in 3 ways. I need to differentiate TH1 way. Interleukin 12 does that. And the TH1 differentiated T cell produces interferon gamma, produces M1 activated macrophage. These activated macrophage, good evening DC. These activated macrophages are the one which will be seen in the microscopy. When a macrophage is normal, they are clear, they are foamy macrophages. Circling. The foamy macrophages structure changes, they become a bit elongated and pink color cytoplasm, right? So when they become elongated and pink color cytoplasm, let's say they look like this. Nucleus is there along with a pink color cytoplasm. So the first person who saw this cell look like a columnar epithelium. Nucleus in the corner, cytoplasm is there. So he said that it looks like an epithelium. How do I name it? Oid, fibrinoid, right? Like an epithelium. I named it epithelioid cells. That's all. So granuloma is nothing but epithelioid cells. Those are the principal cells of the granuloma. And there will be thousands of epithelioid cells. They can't keep quiet. They'll say that, let's form a gang. The gang is nothing but giant cells. Giant cells are nothing but union of epithelioid cells. So they'll have one nucleus or more than one nuclei. 100% more than one nuclei. And these both guys will produce interleukin 1, will attract WBCs, lymphocytes. So peripheral cuffing of lymphocytes. Center, I may have necrosis or may not have necrosis. If I killed the bacteria, yes, I'll have necrosis. I didn't kill the bacteria, I'll not have necrosis. That's what I see in granuloma, right? That's a beautiful explanation of a granuloma. They can even ask, why do I name them epithelioid cells? A reasoning why question. Because they're elongated, the structure changes, looks like an epithelium, so we call them epithelioid macrophages. They are not epithelial cells, they are macrophages only. Fine? And they are the most important cell in granuloma, right? So now, when I write granuloma, obviously I have to write, how do I identify granuloma? Because every granuloma looks the same. Is there any clue for me to identify granuloma? Based on the giant cell, I can say, okay, this is the most likely cause. I have Langerhans type of giant cell, the U-shaped arrangement or an horseshoe-shaped arrangement, tuberculosis. This calls a circular or wreath-like arrangement, right? We call them two-tone giant cells seen in Xanthoma xanthelisma. I don't have any specific shape like this, haphazardly arranged giant cells. We call it foreign body granuloma seen in foreign body giant cells. It's a clue for me. Because the ultimate goal for me is everything in chronic inflammation produces granuloma. How do I know it's TB-related granuloma or a foreign body-related granuloma? One clue is giant cell. Second is whether necrosis is there or not. Easiest way to identify. If there's a bacteria, my body killed the bacteria, I'll have necrosis. TB, pure nephritic leprosy, coccididio, histoplasma. If my body could not kill the bacteria, still TB is the first cause. Please never forget this till you practice medicine. Center is epithelioid macrophages and a little bit in the corner giant cells. Center, if I can kill, I'll have the necrosis. Fine, DC? Okay. TB is for both necrotizing and non-necrotizing granuloma unless otherwise proved. The question says non-necrotizing granuloma, diagnosis TB. The question says non-necrotizing granuloma, PCR for TB negative, then not TB. Or AFB negative, then not TB maybe. Right? If there's nothing, first diagnosis by default TB. Foreign body can have, someone said IBD, Crohn's disease can have, silicosis, asbestosis can have, Hodgkin's lymphoma can have, and obviously sarcoid also can have. Sarcoid is the last guy. Yes, sarcoid also can definitely have granuloma production, right? Okay, perfect. So there are a few more unique granulomas. These are primarily for MCQs. Stellate granuloma. Kalam, you asked what happens in TH17. See, when TH17 is there, they release interleukin 17 and interleukin 23, which will attract neutrophils. Stellate granuloma is not due to the size. Size is there. They are irregular. They don't look like a star. They are irregular granulomas. But the most important thing is, this is a granuloma which will have, along with lymphocytes, along with your epithelial macrophages, they'll also have neutrophils. That's the most important thing here. The moment I have neutrophils in a granuloma, I know for a fact it's not only TH1, it's also TH17. See, in Cascade disease, lymphogranuloma venereum, I see suppurative granulomas or stellate granuloma. That's why it is famous. Okay. Praveen, it will be there in Medadap. Okay. A type of granuloma looks like a donut, looks like a vada. In center you have a gap, seen in liver and bone marrow. Q fever, allopurine toxicity. I name something called a microgranuloma, where there will be no giant cells and very less epithelial cells, only tiny granulomas seen in toxoplasmas. That is microgranuloma, right? Okay, perfect. Next, sarcoid. Please remember, throughout life, you don't diagnose sarcoid first. There are few diseases across medicine to be written diagnosis of exclusion, which means I exclude every common possibility, then I will think of sarcoid. Never forget this. It should be considered only when all the granulomatous disorders are eliminated. either by symptom or by examination or by lab findings. It is non-necrotizing. The most important thing in sarcoid is they are discrete granulomas. They don't coalesce. TB will always coalesce. They are separate granulomas. They will be independent, right? I'll have one granuloma here, one granuloma here, one granuloma. Why are they separate? The second word has the answer. Perigranulomatous will have fibrosis. They'll have fibrosis around every granuloma, so they don't unite, right? And they are naked granulomas. This can come in a viva. They don't have surrounding inflammatory cells, the lymphocytes. They'll have epithelial cells, they'll have giant cells, but surrounding lymphocyte cuffing will not be there, so they are called as naked granuloma. Again, all this once I rule out everything. One of the most important ways to say it's sarcoid is ACE levels. Acetylcholinesterase levels. If the levels are elevated, it's one of the important diagnostic clue of sarcoidosis. Do remember them, right? Hypercalcemia can be there. That's also a clue, but ACE level is a very important clue to say, yes, most likely this could be sarcoidosis. Fine. Perfect. So we know about chronic inflammation. Done. Okay. Great. Can we go to wound healing? Okay. So wound healing. See, wound healing again can come as short note, very unlikely come as long answer. But the abnormal wound healing keloid and your hypertrophy scar can come in a 2-mark or a viva question, right? Wound healing has two types. One is healing by primary intention. The other one is healing by secondary intention. Both has the same one. Both primary intention as well as secondary intention has the same output. Same steps. The only difference is the timeline is different. Primary intention does not have a tissue loss. Very minimal tissue loss. Fine. Secondary intention, tissue loss is present. No infection in primary, presence of infection in secondary. An open wound. You have fracture, open fracture with infection will heal by secondary intention. Scar formation may be optional in primary, but will definitely be present and will be inevitable and will be big in secondary infection. Obviously, time is more because here I have to create, right? I have to create more lost tissue, so automatically it'll take some time. Fine, perfect. Praveen, it will be there in the Medit app, like I said you. Fine. Kavendra, this, if you have any doubt, please let me know. I'll answer a bit slowly. Hindi is not my comfortable place, so I'll teach in English. Okay, perfect. So now let's go to the pathogenesis and timeline of wound healing. Right? We are going to look at the wound healing of primary intention only. Whenever you have a clean cut wound, surgical scar is the best example for primary intention. Fine. Whenever you have a wound, you will have a clot formation. When you have a clot formation, we call it scab. If you fall down, there will be brownish tissue like that scab. It happens immediately. There's no time required for it. Fine. Please don't remove the scab. If you remove the scab, it will bleed again and healing will be delayed. What is the use of scab? Because here we'll have a gap here, right? There'll be a gap here. Okay. The gap here is going to be if there's a gap, I can't heal. I need a bridge. The bridge is a scab. It's a scaffold for wound healing on which every wound healing happens. Now, in this gap, within 24 hours, neutrophils come here. The primary use of neutrophils is remove every dirt material there, every bacteria there, take care of that, remove organisms. After 24 hours, neutrophil job is done, macrophage comes here. Around day 3, macrophage is very prominent. Macrophage will come inside, macrophage will remove the nucleus, remove the neutrophils, remove something which is left out, fine. Okay, once it's left out, automatically it will go and kind of clear the place. Once it's cleared, they remove the debris, they remove the clear dead neutrophils and they convert into M2 macrophages. If you remember M2 macrophages, the function of M2 macrophages is definitely, one second guys, thank you. The function of M2 macrophages is nothing but to heal. M2 macrophage secretes, we just saw that, M2 macrophage secretes your TGF beta and VEGF, right? So next is granulation tissue. Okay, so once you have the M2 macrophages secreting VEGF, the vascular endothelial growth factor, I have written here, right? That helps in the formation of the microscopic capillaries. Not just capillaries, I need a base again because everything is being cleared. So to form the base, I have collagen production. The initial collagen production is type 3 collagen. They are not type 1. the initial is always type 3, they are less effective collagen, the easiest to forming. They are not strong enough. The moment blood vessels come, the type 3 collagen comes, over the period of time, the blood vessels kind of reduce and the collagen becomes much more firmer and they become type 1 collagen, that is scar formation. The scar tissue, beginning of scar starts around day 7, okay? And there'll be maximum scar deposition around day 23. It's a day 21, that's third week. The first week is where the scar starts. The third week is where I have maximum scar formation. The type 3 collagen will be replaced by type 1 collagen biochemically, fine? It does not stop with scar formation. If a question is coming on wound healing steps, I want you to also include scar remodeling. It's an approximate duration of 3 to 6 months. Slowly, the collagen will break down with matrix metalloproteinases. That also is produced by the same M2 macrophage. They break down the collagen because they have collagenases and gelatinases. And again, I'll have TGF-beta which will reform the collagen. See, if you remember collagen type 1, it's there in bone. Bone does the same way. I'll destroy the bone, reform the bone. I'll destroy the bone, reform the bone. The same way, this also will destroy it and will reform it, right? That way, a scar can be great. It will be decently strong. It can never reach 100%. The maximum it can reach 70%, right? So getting a distinction is amazing, right? Maximum a scar can reach the potential is 70%, that's all. Okay, perfect. Now let's go back to this. So scar, I can use collagen is pink in color to identify scar. There's microscopic stain called as an Mason's trichrome, which can identify the scar collagen in blue color. It's trichrome, 3 colors are there, and the collagen will be highlighted blue in color, fine? Okay, and what is abnormal wound healing? Like I said, these two are things which can come as a short note or 2 mark or in a viva. Talk about abnormal wound healing. Two important things, hypertrophic scar and keloid. Both are problems on the scar formation step. There is no racial predisposition for hypertrophic scar. If you're an Indian, Asian, you are more prone for keloid compared to an American, right? Keloid can be symptomatic or can be even asymptomatic. Itching and pain can be seen in keloid. Sometimes you won't see them also. Hypertrophic scar, you will not even see itching or pain. How do I differentiate them based on microscopy or even gross? Because if no one takes biopsy for keloid, it's about understanding whether it's keloid or not. That's all, right? So let's say I have an injury here. If the scar is big and only in this place, fine, that is hypertrophic scar. If an injury here, the scar goes beyond it, okay, that is keloid. Fine. Whenever the wound extends beyond the wound margin, the scar extends beyond the wound margin, we call it keloid. The scar is within the wound margin, we call it hypertrophic scar. Why should you differentiate? Because hypertrophic scar regresses automatically, but keloid is permanent. If it's aesthetically unappealing, I can use treatment of giving steroidal injection of your triamcinolone or surgical excision. Or it's painful again, I can treat, right? Generally, treatment is not required for hypertrophic scar because it's automatically will stop on its own. But keloid requires intralesional triamcinolone. In both of them, if at all they ask microscopy, I'll have abundant interlacing collagen is what I see in both keloid as well as hypertrophic scar. But like I said, they don't take a biopsy. It's a clinical diagnosis and they treat if it's required. Fine. Okay. That's about your hypertrophic scar and keloid. Fine. Okay. Okay, guys. I'll stop here. We have completed both the chapters. I still have generics left and I still have CNS, endocrine, other things left. I'll definitely come live in my channel and I'll complete that because there's 7 o'clock. There's a FARRE session of first year students. So the time will be clashing. That's the reason I'm stopping it here. Fine. Any doubts? Do let me know. Quick reviews and Kavindra Nayak. आप बोला ना क्या doubt है हिंदी में आप बोलिए and I'll definitely answer you. अगर if you don't have a doubt, then I think you ask me something in Hindi, I'll answer. But teaching is, I'm more comfortable in English, I'll do that, fine. Kaleem, next class, next class will be practicals of pathology, which will be there on Monday and Tuesday next week. One left theory part, I'll cover sometimes in the weekend in my channel, fine. Thank you guys. See you.